So I hope you've all eaten enough, and I'm just going to ask you to quieten down a little bit, please, so I can introduce Manisha Kumar, who is the Chief Medical Officer for NHS Greater Manchester Integrated Care Board. And we're very lucky to have her here today to talk to us a bit about some of her thoughts on health inequalities. Thank you very much, Manisha. You have to press that quite hard, and if you can point it at that. If you can read that better on the slide, they can record you better.
Okay, great. Thank you. Good afternoon, everybody. So, I am not only menopausal, I've also got hay fever, so you're just going to have to cope with me this afternoon. And I'm the Women's Health Lead for Greater Manchester Integrated Care, so I have to declare these things. So, just for a bit of context, I'm a GP. I work in primary care, but the majority of my world is now with the integrated care system. And I'm going to talk to you not just about gynae, but a little bit about inequalities. So we've got a coherent understanding in the room what we think inequalities are, something about how we as complex systems create inequalities. But what I want to leave you with is the thought about how we can then together perhaps do things differently looking forward to reduce those inequalities. So, this is a word cloud which really talks about some of the things that are important to people. And I think we do talk about inequalities a lot, but do we truly understand what that means? We talk a lot about race, we talk a lot about gender, we talk a lot about gender preferences, we talk about deprivation. But what is inequality to you? And you're going to have to forgive me because I'm not allowed to move for the mic, so normally I'd be up and about. So health inequalities are defined as avoidable differences in health outcomes between groups or populations, such as differences in how long we live or the age at which we get preventable disease or health conditions. And it's a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage, often interchangeable with health disparities, and we look at different groups. And some of the groups we talk about are those that are systematically experiencing obstacles to how they gain health. This should all be familiar to you, and these are the common areas which we tend to look at: protected characteristics, socioeconomic deprivation. Do we look enough at geography and the health inequalities that we perhaps create with geography? And as we've come together as an integrated care system across the 10 localities, what we have is a really stark variation in each of the different areas that we've got that aren't explained by the two above, either protected characteristics or socioeconomic deprivation. So what's different about our geography that's creating health disparities or health inequalities? And do we truly understand the value of place and the importance of place? Then, of course, inclusion health and vulnerable groups. And I'm not going to talk about Core 20+5 because you'll hear that in various forums. What I want to do today is talk a little bit beneath some of those headlines for GM. So, levelling up. I can't read the slide from there. So, people living in the most income-deprived areas in England are 20% more likely to have a late cancer diagnosis. Cancer survival is improved for people living in more affluent areas. How many affluent areas do you think we've got in Greater Manchester? Anyone name one? Altrincham, yeah. Bits of Trafford, yeah, absolutely. Anywhere else? Bits of Stockport, anywhere else? And Didsbury, where all the medics live. So that's pretty much it. So you've got very small pockets of affluence. So the rest of our 2.8 million people are living in areas that are not regarded as affluent in the national context, although it is all relative. 70% of individuals with cancer also have one or more potentially serious long-term health condition. What does that mean to us? It means these are people we see every day. We see them at various parts of healthcare, but we're not joining things up. We're not joining up treating or advising people about hypertension with cancer screening and cancer diagnosis. We're treating people in pockets and different bits of bodies. And if we're really going to look at integrated care, we need to start looking more holistically. So deprivation is in the headlines. We see what people are saying every day. But what does that mean in terms of health inequalities? And I'm going to talk you through an example later on that describes how deprivation can really make a difference to the choices you might make as an individual with how you access care. A patient's postcode influences how early they are diagnosed, the treatment they are offered, and ultimately how long they live. And there's an example there about stomach cancer. Now, to me, that feels inherently unfair. So how can we, in a modern world, really say that that's okay? That's not okay. Certain lung cancers are closely linked with avoidable risk factors. Smoking, weight, obesity, alcohol consumption, all of which are more prevalent in areas of deprivation. And those people who aren't living the lives don't perhaps understand why it's so difficult for people to stop. And therefore, understanding what drives people to make different choices is really, really important. And of course, early cancer diagnosis is in the Core 20+5 framework. So cervical cancer, I'm not going to touch a lot on this because Coral's going to talk a bit about screening in the next presentation, but we have real issues with cervical cancer and inequalities. In the cases of cervical cancer, incidence in England is 65% higher for women living in the more deprived areas compared to the least deprived, and mortality rates are 148% higher. So just by the postcode you're born in, your chances of healthy life expectancy are completely different, regardless of the choices you make in your life. Now, again, that's not okay. And what can we do as an integrated care system to make that different for the next generation? We know cervical cancer is preventable. Teenage girls and women living in high levels of social deprivation are less likely to have received their HPV. Lesbian and bisexual women are twice as likely to have never had a cervical smear test compared with women in general. And if you add to that women who are trans undergoing hormonal treatment who would really struggle psychologically to have a smear test if they haven't had any reconstructive surgery, that incidence is even higher. And of course, there's race as well. Afro-Caribbean and Asian females of 65 have a higher risk of cervical cancer. And we can make lots of different assumptions as to why, but what we need to do as a system is to say, well, how do we then change that? Treatment rates. Now, we talk a little bit about accessing pathways, but what I'm seeing at the moment is actually the other end of the pathway is completely different for people who have multiple compounded health inequalities. So people from more deprived backgrounds have a lower likelihood for receiving surgery for small cell lung cancer, for receiving chemotherapy, for receiving combined treatment, and being recruited to clinical trials. Now, if you're in the room with the same diagnosis as someone else, that should not be the case. So what is going on there that even if you are diagnosed, your treatment pathway is different? Then if we talk about research, if you're a woman and a woman from an Asian or a Black African background, you are less likely to be recruited to a trial. Now, why is that? And I think we need to challenge ourselves as to what is going on that we can change that could make that different and really change some of the stats that we're looking at. So, barriers. A lot of the rooms I am in, people talk about health inequalities at the top of every agenda. Let's address health inequalities. What I don't really see is a concrete understanding of how reducing health inequalities needs to be the purpose, not creating more inequalities as the default when you look at an inequality impact assessment. And when we talk about barriers, people see barriers as something physical. I can't get the bus, or I can't afford a taxi to get there, or my language is such that I can't explain what I want. But I think barriers are even more fundamental than that. And if you look at the definition of what is a barrier, barriers are things that make accessing care more difficult, taking more time, costing more, requiring more help, waiting longer. It doesn't necessarily mean that that person cannot access care, so you might have put something in for digital inclusion, but have we still created a barrier? And I think it's important that we dig beneath those headlines to make sure that we do address the fundamental differences. And on the side, understanding barriers to accessing care. Let's look at some key design principles that we really interrogate what we do with that lens of, if I was blind, could I do this? If I was blind and didn't speak English, could I do this? If I was blind and I was living on the poverty line, could I do this? If I had no recourse to public funding, how would I do this? And if we get it right for those most vulnerable people, we will get it right for everybody else. And that's really, really critically important. And what I would like you all to think about today is what interventions reduce that inequity. But most importantly, how do we work as a single system to reduce barriers? Not me doing something in primary care and then now doing something in secondary care. How do we do something as a whole system built around a patient? Okay, so a little bit about strategy. This is the Greater Manchester strategy. How many of you have seen the Integrated Care Partnership strategy for the system? So that's about 2 or 3, and these guys work for the ICS. So actually we need to get that out there, and what I'll do, I'll ask the team to circulate that for you, because it's actually a pretty good document. It's 100 pages, but it does talk about what we want to do in the next 5 years across Greater Manchester, including our work for cancer, to make things better, to make sure that everyone has a fair opportunity to live a good life, everyone has improved health and well-being, and everyone experiences high-quality care and support where and when they need it, and to make sure that health and care services are integrated and sustainable. Because I'm a clinician, so I would argue that poor care is more expensive than good care, whereas some people think good care is more expensive than not affording care. Therefore, screening costs us more money because we get more people going into a pathway, but actually we've got to think over the lifetime of that patient, we have reduced disease, we have got better outcomes, we have treated people earlier, they stay in the system in a different way, they require different support. So we need to start looking longitudinally and whole system to make sure we're doing good care. So, GM, so the statistics I shared with you were national. So what are things like for us? Are we different? Are we better? Are we worse? So we have 2.8 million people in Greater Manchester, and we have an economy bigger than that of Wales. And if you think about the geography, that shows how densely we are all packed in, which could be an advantage for accessing care. If you live in Trafford, can you access screening in Wigan, even if you work in Wigan? Why not? And I suppose it's the things we are creating that make lives more difficult. So we have a really compact geography, but we are reducing people's opportunities to access care just by working in small units of that geography. We've had higher growth than almost anywhere across the country, and that's concentrated in certain parts of the city, particularly Salford and the city of Manchester. Mostly young people who've come in, and therefore we've got a new generation of children living in the city centre and young women who work in a different way, and that's important. We also have some of the lowest life expectancy in England, with differences between the most and least deprived areas of 9.5 years for women and 7.7 years for men, and then further differences between race, ethnicity, gender disabilities, poverty, social exclusion, sexuality and age. So if you have all of those, you're bottom of the pile. Nearly a quarter of Greater Manchester adults are economically inactive, higher than England. And for people from minority ethnic groups in Greater Manchester, employment rates are over 10% below the overall working age employment rate. How does that affect cancer diagnosis, and how does that affect screening? If you work on a 0 hours contract and you're sent an appointment for a particular appointment that you have to go to and you can't change it, you don't go. You just don't go because you can't afford to go. And actually what's important to you now is more important than what's important to you in 6-10 years' time. So people then default from routine healthcare. There's lots of conversation about where the most deprived integrated care system or whether Blackpool is in Lancs and South Cumbria. I think it's a bit of both. I think Manchester's the most financially challenged integrated care system because of the burden of COVID and the burden of disease. We know that patients come to our hospitals with 9% higher acuity than anywhere else in the country. So we have the greatest gap. And the more we can do upstream, the better that will be for us in 5 or 10 years' time. Demand for NHS services. So prior to the pandemic, we were not meeting our national standards for cancer, and we're still not meeting our national standards for cancer. Now we need 5 additional theatres 5 days a week to address the backlog. 2/3 of GP practices are reporting increased levels of demand, with a further 1/5 reporting significant or very significant increased demand in February of this year. Over 1/4 of pharmacies, 2/5 of dental practices and optometrists are reporting challenges. How many of you have seen a Lloyds and Sainsbury's lately? So they've all closed down because it is just too difficult to deliver healthcare in those settings. And all that does is it's that toothpaste tube of demand, and things like screening, cancer awareness, education become the last thing you do because you're always dealing with that tip of the iceberg and responding to disease rather than health. And therefore, we're going to constantly stay on that treadmill of being overwhelmed unless we can find a way to step a little bit further back and look at that from the lens of inequalities and say we have to focus on the things that make things different. And of course, NHS resources. So our budget is 6.5 billion, sounds like quite a bit. We are currently 650 million short of what we need to deliver this year. So That's huge. And how do we then continue to deal with the demand with that degree of a gap? I've got to say, that's taken up most of our world at the moment. So pressures on the health and care workforce. Can I just check how many of you here are clinical? How many of you have got a full team? That's not bad. I'm pretty impressed, because actually, if you look around a lot of clinical areas, people are working with a lot of vacancies, just because we're not getting the health and care workforce in the right place for where we've got need. As a whole health economy, we have more people working for us than other comparable ICSs, but they're not where we need them the most. So we need to look at recruitment and retention. We need to look at recruiting from within our populations, because that really makes a difference to people staying in challenging areas to work. Lack of diversity amongst our workforce needs to be addressed, because that makes a difference. I hate the word cultural competency, because I think that almost puts an artificial expectation that everyone needs to be the same if you're a certain culture. I much prefer holistic care, because we need to treat people as individuals. But the more diversity we have, the more people are going to find someone they can relate to, that they can talk to about the things that are really sensitive. And to be fair, gynae cancer is one of those. It is intimate, it is sensitive. It's a little bit embarrassing for some women to come forward. So the more people we can get that might have a different perspective and a different approach, the more likely we are to have a different conversation. So gynaecology in GM. So the pandemic has had a large and lasting impact on our healthcare systems. It's been felt unequally by the geography that we've already talked about and speciality. And a lot of our gynae professionals did move around the system to support other areas during that time. The gynae waiting list has risen at the fastest rate of all specialities in England. That's about 60%, to nearly 460,000 women waiting the 31st of January 2022. Now, I don't refer any women to gynae anymore, because it's either now or never. And if you're going to wait 12, 18 months, then actually their problem's going to either be resolved differently or it's going to be too late. So we're finding a lot more women are being referred on the 2-week wait because of that uncertainty, because there's limited diagnostics available in primary care. I've only got an ultrasound scan, I can't do anything else. So if we need something more, we need to look at how we're creating our systems that we can rapidly get these women through to say, actually, this is something that can wait, this is something we can do differently, or these people need to be fast-tracked, because I'm really worried about who's sitting on that waiting list that shouldn't be, particularly if they've got compounded health inequalities, but more, which women haven't even come forward in the first place to be on any waiting list. I'm not going to touch on these because Coral's going to talk about screening, but as expected, our screening rates aren't as good as the rest of the country. And they're different at different ages, at different parts of those 10 areas. So I'll skip through these because I'm not going to ruin Coral's thunder when we talk about screening. But it did fall in autumn-winter 2022. We're failing our target. Areas such as Manchester, Oldham and Salford having the greatest gap. I was a gynae lead in 2007 when I first started in practice-based commissioning, and we taught then about cervical screening. And there was a study about actually women don't want to have their screening in a GP surgery. I cannot tell you how many smears I've done with babies balanced on women's sort of chests while I do their smear. That's not ideal. So what I really want us to do when we look at system redesign is think outside the box. Women's health hubs, places where we can have creches, where we can talk about mental health, as well as having your blood pressure done. Let's do your childhood IMS at the same time as doing your smear. Let's start to look at families in a different way. And there's a real pull in all localities to look at family hubs, so you don't have to have your smear test with your toddler balanced on you. It is not a great way to have your care done. So what are we going to do about it? So this is the question that sits in my world and hopefully in your world as well. So devolution. What has been learnt? Has devolution been a success? What is the difference between an integrated care system and devolution? What we have learnt is the challenges facing the health and care system can limit improvements in health. We know that. We also know that improving health is not just the role of the NHS, and if people helped us deal with housing and poverty and help us work in different ways with access to stopping smoking, different approaches to mental health, we will see a better approach to physical health at the same time. It takes time to make a difference. We can't work on an annual financial cycle when we're looking at things like cancer and cancer prevention. We need to look longer term. So what it requires is those who are really invested in making that difference to speak up and say, this is going to make a difference today. It's not going to give you a return in 6 months, but in 5 or 10 years' time, we will shift the dial. And I think there's a real movement needed for prevention, but not prevention just in terms of stopping smoking or looking at your diet, but that further step, screening, secondary prevention, health awareness, living healthily, and how we can do that together. Which is the next point, working in partnership with people and neighbourhoods makes a difference. We need to go right down into communities. Who are the people you listen to? So, another quick survey. How many of you listen to your mum? I'm hoping my daughter would say the same. How many of you listen to your children? So, what about the matriarch? If you've got a cultural matriarch, how many people listen to a community leader or someone influential within your community? How many of you listen to your GP? So I'm not the best person to be doing this, am I? So we need to be educating the people who influence you. We need to be educating our young people. We need to be going to schools, which we talked about earlier. We need to be looking at community leaders. We need the voice of people within those neighbourhoods to say, I've had have you? I've been here, have you? If you've got something intimate that you're not sure about, having someone older to talk to. We've lost societal seniority. How do we get that back? By empowering communities to talk about some things that aren't always as easy to talk about. Relationships and leadership are crucial. And leadership, that doesn't mean people like me in fancy jobs. It means all of us as leaders in the room, because you are leaders of your world, and that's important. Holding each other to account for the change. Governance and structure both help and hinder. Always happy to do another presentation on clinical governance, not today. And the challenges to integration are common to all systems, including local authorities, including systems within systems. Reaching and supporting those facing the most entrenched inequalities and disadvantage requires radically different approaches. This challenges traditional models of universal service delivery. Are we ready to be radical when it comes to gynae cancer? Because I think we're going to need to be. Intervention should be designed to align uptake with the distribution of need. How many of you heard of proportionate universalism? So that means you give more money to those who need it most. We give more care and more opportunity to those who need it most. But that means those who need it less get less. And at the moment, we don't do that. We operate very much on fair shares. Are we really ready to say, well, these communities need a different approach. It's going to cost us more. We're going to put more there, because that requires really brave intervention. But that almost is what we need if we're going to look at health inequalities in a different way. We need to do things earlier. We need to achieve more equal outcomes, and we need to remove those barriers once we understand what barriers we have created. There's some link there if you want them. So I put this up there because I don't think we always realise what we do. So I'm going to put my own service on the line. I'm a GP. We have, I think, good access if you are speaking English, can use a computer, can come in on the day. You can come in on the day within 20 minutes. But if you want an appointment in a month, that's not going to work for my surgery. So we have created, barriers to health. It's not going to work. Access is difficult. Appointment times. If you have 4 kids, come in at 3 o'clock. You can't come. You've got to go to school. If you're a single mum, you're never going to be able to come at that time. What do we do to offer people choice? You can book the theatre in New York, but you can't book your own appointment at our hospitals universally. I know some are working better than others. Actually, when we can really empower patients to make their choices, we will see different engagement. So let's look at how we create access. And access just doesn't mean the volume of appointments. It means looking at the person in front of you and being able to tailor what you do. Communication, language, interpretation will help. If you've got a woman with an early vulval cancer, having a male interpreter is not going to get you anywhere. Having a male sonographer for some cultures is completely untenable. So what do we do about creating a different level of communication? We assume if someone speaks a language, they also read that language. They don't. And do we know what language people speak? Do we know what dialect they speak? And do we know what level of understanding that they have? And we are trying to look at this, and I think all of us are measuring that in a different way, but we're not doing it once, we're doing it 10 times. So what could we use in terms of tools like the GNCR to really understand a person's communication needs? If you are sight impaired, it's not necessarily Braille that you want. You want a certain font at a certain size, and that is individualised to your treatment. Do we do that? Legally, we are supposed to, but I don't think we do. And I think we could look really closely at how we support communication for the letters that we send out. Treatment offer, I've spoken before about biased clinical decision making. I don't think that's conscious bias. I just think we treat some people differently. And that's an internal conversation, I think, for all of us to have as to why. And being aware of unconscious bias, and it doesn't make you a bad person. The more you deal with what makes your own assumptions, the less they will be prevalent in the changes and decisions that you make. So let's own them, let's admit them. And then, of course, recovery. Are we prepared to do things differently? So, some things that we have done differently, because I want you to apply this, I'm just keeping track of time. Well, we did this with the COVID vaccination programme. We didn't just say, here's your vaccine, here you go. We looked at access. We went everywhere. We went to schools, we went to mosques, we did vans, we did scale where people felt more comfortable. We did clinics just run by women. We did clinics in different languages. We looked at different times of the day, evenings. I think there's an overnight clinic for taxi drivers. You know, we looked at access in a universal way. We looked at the information we were sending out and we tailored that to different generations. The information we provided an 80-year-old woman was different to an 18-year-old lad because they needed different information. So we changed what we did. And we looked at motivation. What makes you do the things you do and what makes you not do them? And again, I think that goes back to the trusted people within your sphere of influence that can then change your motivation. And some of that takes time, but it doesn't mean that we don't start. I'm going to flick through a couple from National about interventions to reduce health inequalities. There's different places we can intervene to make things different. We can intervene at different levels of risk. Are some women more at risk than others? We can intervene differently there. We can look at different impact over time, and we can look at different impact depending on what age you have. And I think if you cross-sect things in different ways, we'll start to get different plans. This is for your finance teams to say that the intervention will give you different returns. Please use this. They need it. And of course, we can do things at civic level. You know, we can change the price point of alcohol. We can look at smoking in a different way. We can look at community-based interventions about how we have access. And we can look at service-based. But in the middle are place-based systems. And my job is to help bring down some of those barriers between those areas, that from a person it's seamless when they move between them. So, this is my favourite slide, and it's about perspective. So, when you look at something, how often do we look at it from somebody else's perspective? And the next couple of slides, I just want us to touch on putting ourselves in other people's shoes when it comes to health inequalities, and really trying to say, if I was you, what would that mean for me? Because when you look at things from different perspectives, you see something completely different. So, if you are from Kuwait and have a cough, you will think of that as completely different than if you are from Trafford and have a cough. Because in Trafford, if you've got a cough, let's take COVID out of the equation, self-limiting disease more than anything. If you're from Kuwait, it's TB. So your presentation is different. So you've got to look at people's health beliefs and where they come from, and therefore why they respond in a certain way to what we think are perfectly reasonable ways of supporting care. So this is a really busy slide, and I'm going to very briefly go through it because I see this every day. And this isn't tailored just to gynae. It's about how we as a system have created barriers, and therefore we are perpetuating health inequalities. So person A comes in, they can't get into my surgery, therefore they leave it late. They leave it a week, they leave it another week till they can phone at the right time. So they're scared as they don't read or understand English, and they don't really understand the consultation they've had. So with that, we referred them. They didn't understand the letter or the priority. They didn't understand it was a 2-week wait, despite the fact the person in the surgery gave them the standard letter you printed off your computer system. They didn't get what that meant. And they couldn't come within 2 weeks because they needed to have a way of looking after their children, and there was nobody there to do that. So they needed to get a friend to come in. So they missed their appointment. We get lots of letters back from the hospital saying, you've missed your appointment, you've missed your appointment. The patient gets calls. They've changed their number because they've got a pay-as-you-go. They've lost it. Therefore, they can't get back in touch with us to tell us they've changed their number. And therefore, that pathway is delayed. Finally, they get referred to and seen by specialist service. You have to have surgery for your gynae cancer. But again, you've got no childcare, so what do? You can't give your children into social care. So you delay it, you find a way, you find until you find someone trustworthy, or I've even seen people leave their kids with people who aren't trustworthy because they've got nothing else they can do, because they are single parents with poverty and they have no family or friends infrastructure. So that means their care is significantly delayed, their prognosis is worse, their opportunities for further treatment are different. They come back out, they don't understand their prescriptions, they don't have them, therefore they don't receive the same aftercare, they don't attend aftercare appointments because none of those barriers have ever changed, and therefore they have a worse outcome, disengage, and possibly die earlier. And we do this every single day with everything. So that's not okay. So we need to start looking at that. My final slide, which I think it is, it's about person-centred care. So in everything I do, this is the most important thing. It's really hard to do person-centred care for 2.9 million people, but I think that's what we need to do. We've got 82,000 healthcare workers across Greater Manchester. If we took, I don't know, a couple of hundred each, let's try and see what we can do about making things different. Thank you.
Thank you very much, Manisha. Anybody got any comments or questions they'd like to ask Manisha? Carol, you're not going to give the answer in yours?
Well, how can we help? What do you need us to do?
I think we need to think outside the box. I think we need to look at everything we do in a way when we can say, can everybody do it? We talked last time when we first went about early cancer diagnosis, how we can make screening different, how we can look at appointments differently, how we can look at self-booking. I think we need to embrace technology in a slightly different way that will allow us to do that. But if someone doesn't do what you think they're going to do in a pathway, just stop and say, why? And then phone them up and say, you haven't come, but in a way that's not punitive or, oh my God, great, they're off my list, but in a way that says, okay, what can we do? And I think the more we start individualising and learning, then the systems will follow. So we can look at it from both areas and meet in the middle. But I think we have to do something. And it's okay not to get it right. I think sometimes we think we have to have a perfect solution, but we don't. If we get it wrong, we're starting from a place of experience, not from the beginning. So we'll just learn and build on that.
Thank you. So quite an overwhelming problem, but we've got to start small. Thank you very much, Manisha. I'm going to introduce Coral Higgins now, who has defined her job title, following Pathway Forward, as one of our cancer commissioning managers across GM. And she's going to talk to us specifically a bit about cervical screening and health inequalities. Thank you.
Thank you. Hi everyone, it's nice to see you all today. I have to say this is the first time in about 4 years I've actually talked to a real live group of people. Usually I'm sat at home on my laptop with all my notes all spread around the room so that I can look like I know what I'm talking about. But yeah, so I'm a cancer commissioning manager from what was Manchester CCG, but now called Manchester Integrated Care Partnership. So we're all part of NHS GM now, but we still have those 10 locality teams for each of the 10 boroughs across Greater Manchester. So I've developed a bit of an interest in cancer screening. I think this kind of arrived just sort of as COVID hit really, because suddenly nobody really wanted to, we had to leave the providers alone when it came to cancer waiting time. So I started taking a bit of an interest in cancer screening. The primary care contract now has cancer requirements, which includes improving uptake and coverage for cervical and bowel screening. Oh, sorry. So this slide, this is just to show you the variation in cancer screening coverage by the different localities. So you can see on this graph that there's much less variation for for the upper age band, so the 50 to 64 age group. But if you look at the younger women, the 25 to 49 age group, you can see that there's quite a range in coverage. So you can see Manchester there down at sort of around 57%, which goes up to 74% in Stockport. And these are all the same women, same age. But what we do know is, thinking back to Manisha's slides, those women who come for screening are the ones that don't get cervical cancer. So that's why it's really important that we do keep making sure that we get these women to attend. So this is the, so I'm just talking about Manchester now, City of Manchester, rather as opposed to Greater Manchester. So you can see here the decrease in cervical screening coverage over time. Again, less reduction in the 50 to 64 age group, but those younger women, you can see it's gone from 63% down to around 58% in last year, and it's continuing to just drop by a few percent each month. So what we can do now, so we know Manchester's now a cervical screening, a bit of a hotspot, so we can look at the different areas of the city, and this is broken down by what we call our primary care networks. So again, you can see there's a bit of a dip there, the 50 to 64 women, there's a little bit of a dip there in that's Human City South. But again, if you look at the right over on the left-hand side there, we've got about the 3 PCNs where the coverage is much less than 50%. And this is Moss Side and Rusholme, Human City South, Ardwick and Longsight. So these are all parts of central Manchester, and we do tend to have a much younger population there, and they are quite culturally diverse. So in Manchester, we've been quite keen to look at our health inequalities, but we want the data and the information to be able to guide us. So our data quality and our BI team found a way to pull data from our primary care records and correlate that with cancer screening coverage. And we can split that by different health inequality characteristics. Now, I have to say this is not published data. We're not using it for any kind of performance monitoring of the practices or the PCNs, but it does help us to guide where we might need to go in and look at how we target our awareness raising and our resources to different parts of the city to try and increase that uptake and coverage for our cancer screening programmes. So we can split down by the city, we can look at the PCNs, we can look at the neighbourhoods, we can even go down to practice level, but we do have to be wary of some of those small numbers. And the really good news is that our data quality lead from Manchester, a guy called Matt Conroy, is now working at the GM level for the GM-ICS, so we should be able to replicate this and be able to get this in similar information for across Greater Manchester. So this is some of the graphs that we can take from this dashboard that we've got for Manchester. And you can see here, this is broken down by the different age bands. So you can see there the 25 to 29 age band, 45% coverage compared to the 50 to 54s, where it's as high as 74%. So we know that these women, those young women that are first invited, these are the ones that are not coming for cervical screening. It could be to do with the HPV vaccine and them thinking this is a magic going to protect me from everything forever. But again, we do still need to be targeting those messages to the young women to make sure that they understand the benefit of screening. This is broken down by deprivation score. So the lower the number on the left there, that's the least deprived, and the most deprived right over to the right-hand side. So you can see the least deprived, 69%, most deprived, 64%. So it's not much different, but you can see that little dip in the middle on the top line there. So that low middle deprivation group, 53%. So we think these are probably our key workers. So these are our people, our women in lower paid jobs. So our shop workers, perhaps our carers, our hospitality workers, all people who are probably not able to get time off to attend an appointment, and they certainly probably haven't got time to hang on the phone for 20 minutes trying to book an appointment at their practice. So this is a breakdown by gender, again, perhaps a little bit more useful for things like bowel screening, but surprisingly, 66% of people who are identify as non-female will come for their cervical screening compared to 57% of female. So it is only small numbers, but we do know that our non-binary, our trans population, and people who identify with other genders, they have been underserved for many years. So we do need to be able to offer something that suits their needs as well. So gender and ethnicity are self-declared characteristics. So we do rely on patients telling us about this info. So quite often when we look at some of these characteristics, there's quite a chunk of patients where it'll say not known or not declared. So we can look at broad ethnic groups as well, and you can see that variation there. Less variation with the older patients, but you can see there the Asian patients 46% coverage compared to 69% coverage for our white. So the question then is, so what's Asian? So we can split this down by 19 ethnic groups now, and we can look at some of these groups in a bit more detail. So you can see a range of coverage figures there. Bangladeshi 66%, Indian 39%, Pakistani 57%, Arabic 49%, Chinese 26%. So again, we can use this information to guide some of our engagement resources to those particular communities. We can also look at language, as spoken language. As Manisha says, spoken language doesn't necessarily mean readable language. But we can see here Urdu, Bengali, Punjabi, very similar to people who speak English, whose main language is English. But we can see the lower coverage for Cantonese and Mandarin speakers, as again also Arabic. But also we've got on here Spanish and Polish. And again, final one really, we can break down by people with a known learning disability, SMI, serious mental illness, and autism. Now, when we've looked at the figures, the coverage for women with SMI or autism is very similar to those without these conditions. But we can see this lower coverage in women with an LD. So what we've asked is that we could have cancer screening questions on the annual health checks for patients with an LD or an SMI. So you can see here that we've been able to identify areas of the city where we want to go in and do some engagement. We know about the younger women and the age bands, and we know about the lower and that low middle deprivation group. We know about the different ethnic groups we need to engage with and the languages that they're more likely to speak. So we have a screening and IMS clinical nurse in Manchester called Annie Barton, and she's currently working with 8 practices that we've identified with the lowest coverage. We identified these, that they've all got less than 40% coverage. Again, don't forget, our target is 80%. We've provided each practice with a checklist of key actions that the practices could do to try and encourage uptake of the screening offer and access to different resources. We've done some scoping about whether these practices have extended access and if they're using it for cervical screening. And also we've looked at some of those booking processes. So it doesn't have to be making a phone call. Could it be booking through a website or in response to a text message? We've trained some of the GM training resources for that cervical sample takers, because some Manchester practices don't have a practice nurse at the moment that's trained, or they may have locums that are coming in. Annie's also doing some work with the University of Manchester, looking at with the overseas students, because many, and we're also looking at the practices, because quite often some of these overseas students may have moved on, but they're still on the practice list, and it's about how do we get those patients deducted if they've not then gone on to register with another practice. One of our partners is Answer Cancer, that many of you will be aware of. And we're using the data that we've got about Manchester to guide some of Answer Cancer's engagement work, especially with regard to the young women. So they're doing engagement work with mums and baby groups across the city, talking to the homeless women and some of our vulnerable women, refugees, asylum seekers. They've also developed a workplace pledge called Be Seen, Get Screened, and they're trying to get sign up, and they have got sign up from many of our major employers, so Greater Manchester Police, the Fire Service, and this is about our main employers making sure that they're telling their workforce that they can have time off to go for their screening appointment. So it's mainly around breast and cervical, and it is mainly women, obviously. But it's about making, even though they probably could do this anyway, it's about making it more obvious and more clear that people are entitled to have this time off. And this is just a few slides from one of our VCSE groups. So this is BodyFit Active, and we've commissioned them to deliver some engagement sessions with our Pakistani women. So they're doing sort of a whole morning of health talks, specifically about cancer screening, and then there's lots of dancing afterwards and a nice healthy lunch. And what we want to do is, given the information that we have now, is can we do something similar for our Chinese community, Indian, Arabic women? And we've submitted a proposal to the Cancer Alliance, so it's just getting finished now for some comms and engagement funding. And I would like to use this to develop some of these community engagement events. What has come up, though, from some of the events that we've been attending, there are lots of those cultural issues, and we really do need to be very sensitive, and we need to start from their place. This is not just about women choosing not to come for their screening. You know, as Manisha's identified, lots and lots of reasons why they can't come or they don't understand about coming. And one of my GPs in Withington said, you know, if I have a 25-year-old woman who's unmarried, who's just arrived from Somalia, why am I forcing her to have a cervical screening if she's still a virgin? You know, I need that woman to have that relationship with me and that trust in me, so I'm not going to force her. So I think there's no one big thing that we can do to improve uptake with cancer screening and coverage of cancer screening. I always talk about something called 100 nudges, and it's a bit like the British cycling team back in 2008 when they made lots of little changes to the bikes, to the helmets, to the diets of the athletes and the training schedules. And I think that's what we need to do with cancer screening. There's no one big thing. We just have to make lots and lots of little changes and hopefully get that cumulative effect. And thank you for listening.
Thank you, Coral. That was really good. Any questions or comments for Coral? Manisha? Do we have the microphone for Manisha, please? Do you want to use the microphone?
Thank you, Coral. That was really helpful. What do we know about the Chinese community that means that they're not engaging or not coming forward? Have we got any intelligence about the differences there?
Again, what we think is that they possibly are screened in their home country, and when they move to the UK, they will have said, well, I've had my screen last year, why should I have it again? But obviously our programme doesn't accept the results from other countries, so it's not so much about we do need to engage with the women, but we need to understand. And I think those kinds of questions, there is something about patients hanging around on practice lists as well, that if we could find a way to be able to deduct them, it's better for the practices obviously as well.
Thank you, Lisa.
Always does better, doesn't it?
Yeah.
Why?
Don't know.
For years.
Ladies at lunch.
Maybe. It's because I live there. Must be something that we could...
Again, this ties into the health inequalities and the access and ease.
But there's plenty of poorness.
Yeah. Maybe it's spoken about. I don't know. I mean, this is about going into schools, about a societal approach to it. If everybody's doing it, it's more normal. If you're in pockets where very few are doing it, it kind of perpetuates. And I think some of the discussions you had were really intriguing about the BodyFit, where some of the you gave a great story about the older woman guiding the younger women who raised concerns.
So one of the older ladies put her hand up and said, will this affect the young ones? They worry about them losing their virginity from having the speculum. So we were able to say, no, that's not how it works. But there was still quite a few younger ladies who were shaking their heads going, no, not for me. So we've still got a bit of work to do, but if we can use the older ladies, like Manisha said, the community matriarchs, the community aunties, to persuade the young ones, this is okay, don't worry, this is a good thing. But, we do have to think about that there is that association with, I'm not sexually active, so why do I need to come for cervical screening?
Yeah, basically they'll trust their own more.
Yeah.
But these more difficult to reach groups. Thank you. Any other comments or questions? Apart from well done. And this is just starting to scratch the tip of the iceberg, isn't it?
Yeah.
Where you can then look at more closely those areas and see if they do need more resources.
Yeah.
Another one that always struck me is high female employers. NHS is one.
Yeah.
Look at us. Stand-up men.
Yeah.
Anybody need a smear? Just outside, left,
That's a good
left and
point,
left.
actually. I was at MFT had a health inequalities workshop a few months ago, and one of the questions we said was, all these female employees at the hospital, why do they have to leave to get their smear? We've got a St Mary's Hospital. Can we have a smear clinic, please?
An offer here, smear.
About to talk about it.
Yay!
Excellent. Well, just to big up Bolton, we've restarted our staff monthly smear clinics. We trialled that at the start of COVID, and we're bringing that back in because it's very well received, and for all grades, medical staff, domestics, everybody, much easier if they can come and get them done there.
Yeah, brilliant.
Perfect. Thank you. Okay, believe it or not, we've got a cure from Jen. Jen, are you able to talk now? So I've got Jen Davis Oliveira. Is that right? Thank you very much. Clinical research fellow that some may have seen at the recent Gynae Cancer Conference, who won the prize for the presentation for a research project. And she's here to enlighten us all about some work she's been doing about HPV and how we do smears in MFT.
Yes, for sure. Now the clicker will come and haunt me. So, thanks so much. And first of all, amazing work that you're all doing. So thank you so much from everybody in Greater Manchester. I'm a bit shocked that there's more people in Greater Manchester than Wales. I am Welsh. But we do have a lot of sheep, but I'm not sure they have HPV problems. I'm not sure. But anyway, thanks so much for, I'm very humbled to be able to come and talk to you about our work at the University of Manchester and at St Mary's. And I guess I'm here to offer a bit of hope, really, because we've looked at all these figures that are really quite depressing, actually, when it comes to health inequity. And part of what we're doing is really thinking outside of the box. And this is really mainly thanks to the brainchild of Professor Emma Crosby, so she's really all to thank. But I just happen to be really lucky to be able to be part of this journey. So hopefully this will be really interesting to you all. But really, we're hoping to be able to increase the number of people having cervical screening through an alternative method. And I'm essentially a gynaecology trainee, a senior gynaecology trainee, but currently doing research, which is super exciting. So I also go to colposcopy clinic and treat people with high-grade cervical disease as well. So I sort of see them through the whole pathway. So a bit of background. So HPV causes cervical cancer, and it's super common. And unfortunately, this is not well advertised as to how common it is. It's not something to be ashamed of. Pretty much everyone gets it. That's 80% of the population, with 40%, about half of those, getting the high-grade types, which cause cervical cancer. And it is spread through sexual contact. And however, we've been talking a lot about people saying that they've never had sexual contact. And their risk is probably 0/really low, if that is the case. But we would still encourage everyone, obviously, to be screened, because we don't completely know. We can't say for certain that they're not going to have it at all. So we know it also represents not just a health inequity in this country, in Greater Manchester, but also worldwide. So unfortunately, there are countries with no screening programs. We are truly blessed to have one since about the 80s, and we know that it's reduced cervical cancer deaths by 70%. I mean, it's incredible. But unfortunately, this is the vast majority of the world do not have this. So women die of cervical cancer. And specifically, if you see all the red areas there, that's Africa, especially sub-Saharan Africa. So, we also need to be looking globally at how this is having a huge impact in other countries. The world, so much so that the World Health Organization, just before COVID hit, actually launched a campaign to eliminate cervical cancer. And their aim was to get 90% of young girls vaccinated, 70% screened, and then 90% treated early. So that's the aim they have, and they want to make big strides by 2030. Of course, COVID has probably scuppered it a bit, for sure. But in this country, we're doing pretty well on those numbers, actually. But COVID's definitely had a negative impact. And we now have an HPV coalition, lots of experts, lots of stakeholders, community members coming together to think about a strategy as to how we can get to these numbers in this country. And that's me in Parliament. It was super exciting. Emma was on holiday. I got to go. And that picture is really interesting because I actually wasn't in that group at all, but I swung around at the right moment, and there I am next to incredibly important people. So I'll have that forever. So vaccination, so we can eliminate the disease because we have vaccination. The other point to make from what we've discussed is that we know that the vaccination reduces, if it's given pre any sort of sexual contact, we know that it can reduce cervical cancer rates by 90%, which is awesome. However, remember, there's a whole host of us that haven't had the vaccine, first of all, so we're at risk. There's also a whole host of people not being given it because, you know, people don't want, there's a lot now of people not wanting vaccines, being quite scared of vaccines. And also the vaccine that has been given to everybody sort of under 30 covers for 2 types of high-risk HPV, which cause 70% of cancers, but there is a third of cancer being caused by the other types. So everybody who's been vaccinated will not have been covered for these types. So it's super important that these young people that have been vaccinated, so that 25 to 30-year-old group that aren't going for screening, and I think part of it is probably, I mean, when I was that age, I thought I was indestructible. So, you know, part of it is also that, I think, as well as the vaccine, having had the vaccine, but they do still need to be encouraged to go, for sure. So anyway, currently we screen with, as we know, with quite an intimate, invasive examination, the speculum examination. And even as a gynecologist, I find it weird. So I'm sure everybody else does. It's not the nicest thing to do or have done. And then we take a sample from the cervix of the cells. We then test them now for HPV, the virus. Before we used to just look at the cells, very labor intensive and also not that accurate. So it only picked up 70% of abnormalities. Whereas we know that if you're HPV positive, it's a lot more accurate. However, loads of people have HPV. So we then need a second test to sort of triage these people. So if you're just HPV positive and it's a transient infection and it doesn't cause abnormal cells, then you don't necessarily need to go to colposcopy immediately. So we have that cytology, looking at the cells under the microscope, as a sort of secondary reflex test to know where we need to send people. And if you've got high-grade changes on that cytology, you go to colposcopy quicker, which is great. So that's how we currently do it. So what's the problem? 1 in 3 don't go. And in fact, you know, looking at the Chinese population in Greater Manchester, you know, we're talking about only 1 in 5 people going for screening. So there's a huge health inequity here. Why? Well, it's a little bit, we've already alluded to it. Making an appointment when you're, you know, busy working with kids, etc., really difficult. You also have to not be on your period. You know, there's loads of barriers here. But of course, the biggest one is going to be the embarrassment and the discomfort of the actual examination. And we know, and we've talked about it already, the health inequities exist in communities such as the LGBTQIA+ are far less likely to go. People who have disabilities, people who are poorer, people who are from diverse ethnic backgrounds, and also younger people. So, essentially, we want to break down barriers. And because we've switched to HPV testing, we can actually detect HPV not just on the cervix, but in the whole part of the lower genital tract. So we can do that with a vaginal swab. So imagine the cells of the cervix, they slough off just like the cells of our skin. They go into the vaginal mucus. You've all had lunch, right? So it's okay. They go into the vaginal mucus, and that could be picked up with a swab. I describe it as a COVID swab for the vagina, but a lot more comfortable, by the way, because I absolutely hated those COVID swabs. I mean, let me never do one again. But this is a lot more comfortable. And also, that mucus can sit around the urethra where you wee from. And if you collect the first bit of your wee, that wee will flush that bit of mucus into this wee sample, but it has to be the first bit, and it can detect HPV. So it's really exciting. So vaginal sampling is already in 9 countries as a primary cervical screen, which is incredible, and in many others as a screen for people who don't go for screening, so those that are not choosing to do cervical screening in the normal method. So it's being used, we need to use it. We need to be pushing this forward. And luckily we do have 2 studies, feasibility studies in London and Manchester, looking at whether we can introduce this. And I think in the coming few years it will be introduced, which is really exciting. It's super acceptable, people do like it, but there are a couple of things people worry about. Doing it properly, which is interesting. So there's that whole aspect where am I actually doing it right, and can I trust the result? That can sort of be overcome as well by maybe a healthcare practitioner helping somebody to do that. So getting rid of the speculum, but having an appointment and then doing the swab. So that's a possibility. But we also know it's just as good at picking up HPV as the cervical sample, which is really exciting. However, as we know, I'm wondering if this will work, my video. I mean, this is Oscar nominating, right? I'm really sad that you can't see it. Any tech experts in the room? Anyway, so vaginal sampling is great. However, in studies, there's only been sort of up to 20% of non-attenders that will return a vaginal swab. So that's 1 in 5. So how can we capture more people? And so looking at urine was an idea to do that, as urine does pick up HPV. So what we did we know that it's really acceptable, more so than vaginal sampling. And we also know that it does actually have some accuracy for detecting HPV. It's just that one there. This is what we call an AO. Yes, there we go. Thank you so much. So essentially, I talked about how we need the first bit of urine, right? And it's actually really difficult. Anyone used a pot to collect urine? Not males. Males cannot answer this. It's far easier. So really hard. And also like often urine on the fingers, like not sure how full the pot is, really difficult. And so the sterile pot is cheap, but it's really difficult to collect the first bit of your urine in. And imagine if that little bit of mucus with the HPV in it just kind of, overflows and goes out. So then you get an abnormal or a result that's not accurate. So the Colli-P is a device that a Belgian company came up with. If you want to put shares in anything, please do that now. I can't now, I have a conflict of interest, but no, really good idea. Nova Sanis is the name of the company. But they came up with this Shiwi, essentially, and the Shiwi is fantastic because it's a funnel shape, a lot more friendly for a urine sample from a woman. And there's that little tube with a preservative in it. The preservative is really important because it actually stabilizes any DNA in the sample. And you put that on, and essentially the first bit of your wee, if you collect it in that funnel, will actually go into that tube. Did you see the video? Yes. And once that tube is filled, then the rest of the urine comes out through that little chute. So you don't actually have to put it in and out, and you don't have to worry about, not filling it too much. You just do your whole wee through it. So it's a really nifty device and really acceptable. And what we did, let's go to the next slide. So our aim of our research was to establish whether Urine is just as good as a cervical sample at picking up HPV, and therefore we can recommend it as part of the NHS screening test sort of repertoire. And Public Health England's super interested in this, as are Cervical Screening Wales, which obviously I'm very happy about. So we did the ACEs colposcopy study. I collected a lot of urine. I am now a urine expert. And what we did is we actually compared how good the colli-P was versus the sterile pot. So it was a randomized control trial. Because, hey, if the sterile pot worked just as well, why would you need to spend money, a bit more money on this colli-P? And actually, well, I'm going to tell you the results, so it's quite exciting. But essentially, I was looking in a colposcopy population, so they've all got HPV. Half of them had high-grade disease. So we wanted to make sure that the urine picked up HPV on those with high-grade disease, because you do not want to miss people that have disease, right? So that's what we did. And we also wanted to see how acceptable it was. So that's me really excited on my last day of recruitment. That is like 550 people in, right? And it happened to be, was it a special day like World Cancer Day or something? Yeah, which I didn't plan, but you know, sometimes these things happen. So I was in St. Mary's collecting a lot of urine, 2 different devices, and 480 with half of them with high-grade disease. And we tested via the Roche-Cobas, which is a PCR test that picks up HPV that we use in Manchester. And excitingly, what we actually found is that urine really, with a colli-P, right, if we collect it with a colli-P in this population, for high-grade disease, it's really very good. So we looked at about 92% sensitivity, and in terms of comparing it to cervical sampling, it was 0.92 in terms of relative sensitivity. So it's not quite as good, but it's pretty good. And we think that we can make it a little bit better as well. So really exciting, whereas the pot was really not great. So this was a great sort of study to show that actually we can't use the pot, we need to use this special device. And it's only £3, right? So, I mean, it's not terribly expensive. What we're doing currently, and we've probably recruited about 800 patients out of 1,500, is going to the GP surgeries where people have their general screen, and we are doing the same thing, so collecting the urine of those that are doing a general screening. So not the high-risk population from colposcopy, but the general screening population. So if anyone wants to help us with that, again, just outside, we've got some of these wee devices, no. But what's really, I mean, talking about screening for staff, we have approached the powers that may be within MFT and St. Mary's, and we are hoping to be able to offer staff members a smear on site, but also hopefully they'll give us their urine beforehand. That's the hope. But what a wonderful way to be able to recruit to this study, but also offer that. And also, if that works, then fantastic. Let's offer smears in hospitals or in healthcare, bases where people can go, So it was acceptable. colli-P was probably more acceptable, the funnel device, than the pot itself, which I'm sure you can understand why, because it is just more nifty. But people, even in colposcopy, who have been for smears, actually were like, yeah, I'd do a urine sample, which is really exciting. So then I was approached to look at health inequities within the LGBTQIA+ community. And so we did a survey to ask members of the community how they would feel about self-sampling methods, including vaginal, but also obviously urine. And we really wanted to know what the barriers were, and also whether, self-sampling methods would improve uptake in this community. And it was really exciting because what we did is we co-created it. So we had a Zoom, and we had quite a few people from the community, both cisgender, transgender, giving us their opinion on sort of what to ask. So we co-created a survey, and they shared a lot of personal accounts of screening, important topics for this community specifically, and then we collected survey data. Did it via Twitter, which obviously has its limitations in terms of maybe the older demographic, but we did get 503 completely completed responses, which was fantastic. You can see that we got mainly from Greater Manchester, London, Bristol, poor representation from Wales, which I'm very disappointed about, but a whole host of different sexual identities, and also half of them were transgender, which is amazing, because this is a community that really is very difficult to engage with because, of lots of different barriers. So really excited, and clearly a really important topic for them. So important work. And obviously the age demographic was mainly younger. So we asked them a little bit about their knowledge around HPV. And what's really interesting is that everyone knew about HPV. They knew it caused cancer, most people. But the majority didn't think they were at risk of contracting HPV. Now we all are, so pretty much. So that was interesting. So I think a lot of engagement work to be done, a lot of educational work to be done around HPV testing, which I just don't think we've at all really addressed for everybody, but specifically for this community, according to these results. And interestingly, asking about being open or not about their sexual and gender identity and whether that impacts on their screening experience. And interestingly, those who identify as trans, it was more likely to impact on their experience than those who are cisgender. So definitely, something to think about in terms of sort of being a healthcare provider and offering that service to someone who is gender or sexually or has a different sexual identity. So for those who are cisgender, interestingly, the barriers are very similar to what you would imagine it being for sort of a heterosexual population. So a lot of it is about the discomfort, pain, embarrassment. If we look at those who identify as trans, the higher, obviously they're still worried about all of those things, but it's actually more about the gendered environment, the judgment from healthcare staff. So there's a lot of work to be done there in terms of education and, improving that experience between somebody who's transgender and the healthcare setting. It's a huge barrier, actually. And obviously, self-sampling will help get them screened, hopefully, from a cervical screening perspective. But, there's also other health issues that people have, and they need to feel comfortable going to their healthcare provider. What could help? So this is interesting because, well, fantastic for us. They want to self-test. This is wonderful. So we're doing the right thing. But also a couple of other things like being offered a smaller speculum. So that's something that comes up time and time again. And also being able to insert it themselves, which is something that is, people just don't offer. So that's also something that we can take back in terms of any intimate examination like that and being able to improve the experience for the user. So what we found is that, went ahead there, what we find, urine is in yellow, please note, but what we found that most people, as their first option for cervical screening, that's over 40% of this population, wanted urine screening. And interestingly, the transgender population, it's more like half. A lot of people were happy with vaginal self-sampling as well. And still, what's really interesting here is still like 1 in 5 people want to be screened in the way that we're currently screened. And I think that's such important knowledge because I think we just need to offer a menu to people. People have different reasons for wanting different things, and how easy would it be to just tick a box? Do you want a coli-P? Do you want a vaginal swab, or do you want to go in and have it in the normal way with your GP? Because there are still 20% of people that want that. Was there anything else there? Not really. They wanted it all by post, if Royal Mail deliver, right? So I think I've talked a bit about this. So just to be aware, really, I think, of being cisgender versus transgender and how the barriers are a bit different there. And also we need a lot more education and awareness, especially around HPV. And self-sampling methods are, popular. So we need to, start getting that into our screening program. Interestingly, I then tried to recruit for I'm recruiting for interview studies to try and delve a bit deeper into these issues and self-sampling methods as alternative methods for this community as part of my PhD work. But interestingly, we were famous. We were in the Mail and the Telegraph, really reputable papers. I hope you all read them. Yes, so essentially in our documentation, we describe people with a cervix because we're being super inclusive of people that don't identify as female women. So that was our lingo, and that was obviously passed through PPIE, passed through ethics and everything. But somebody who is anti-trans, because there's a lot of anti-trans at the minute within the current political climate, picked up on this, and we were in the Mail Online and the Telegraph for negating women. I'm a gynecologist. I love women. I do the work I do because, I'm a huge advocate of. So it's very interesting to get that. And I think what it showed me is how easy it is for me to be me and cisgender, and how difficult it is to try and be who you want to be within a society that judges you for no reason, and how important this work is. So, that's how I felt about it. But anyway, I had to lock down all of my social media, which obviously was devastating for me. It's all I do. But I didn't really get any kickback from it. It was all okay. But fascinating, really interesting what the political climate is like now. So then we obviously wanted to look at other groups that are less likely to go for screening. So really excited about looking at ethnically diverse communities. And so we took this survey to different communities that are less likely to go for screening and co-created the survey in a slightly different way, obviously, to the LGBT, and worked with all these incredible people across Greater Manchester who are doing amazing work for ethnically diverse communities. And we've come up with a survey. It is live, yes. And that is the barcode. So if anybody can help get this barcode out to as many people as possible, we really want people's thoughts on self-sampling methods. So this would be amazing if you could help us do that. I think we're probably up to about 50 now. We've also branched out. We're doing paper copies. We're doing it in different languages. So I think we have 7 different languages that are the most sort of spoken across Greater Manchester. So a lot of effort has been put into trying to make this sort of as accessible as possible. And it is difficult when you've got a small research budget, but we've really tried very hard, and people have definitely helped us along the way. So that's what we're doing, and we're really excited about doing this. We're also doing some interviews within certain populations and groups. So this is really exciting work. And hopefully, the idea here really is to give everybody a voice in the future of cervical screening in this country. So yeah, help us if you can. And maybe, hopefully, there's an email list so I can send you the poster out. If you want to print it and put it up wherever you want to put it up, that would be amazing. So thank you so much. So essentially, we've got loads more studies. I'll very briefly go through them. This is the incredible team that we have, because behind every great idea is an amazing team. And obviously, I've spoken about the colposcopy, the primary care, and they're looking at test accuracy, and we're excited that urine works. I've talked about the LGBT and diversity. I'm hoping to go to Kenya, ideally when the weather's really nice, so that I could just go for a month. But no, there's someone out there who's really keen. So there's an amazing Kenyan researcher who wants to work with us and see whether urine sampling could work for Kenyan women. It's cheaper as well, right? So, it really could work and overcome the barriers. So I'm hoping to go and help her set that up. Anybody know of any funding? That would be amazing. And the other exciting thing is that we're going to be looking at sending out this colipy or a vaginal swab to people who don't screen in the normal way. So I think it's called ACE's Choice rather than at home, but this will be, probably in about 6 months, will be open for recruitment. So anybody who doesn't go for the screening in the normal way can actually be screened in this way, and we're trying to see whether people return a sample or not, whether it does actually increase screening, because at the end of the day, we can come up with this great test, but we need people to engage and actually send it back and for it to make a difference. Because currently, cervical sampling is good, it's good, but we want to increase the number of people being screened. So there will be, so watch this space, there will be a study where people will send the pack by post, they can send it back. So that's really exciting. So we're not only talking to people who don't go for screening and asking them their opinion, we're also offering them to be able to be screened in an alternative way, in a research setting, but nonetheless, they will get their results, etc. I'm collecting a bit more urine for those who have had disease and are having their 6-month smear after treatment. So that's another thing that I'm doing. But the other really exciting thing we're doing is, everybody's heard of the lung health check van. There might be vans now, but there used to be one. I know it well. I've been on it. It's in Hyde, various places, but obviously in lower socioeconomic areas in Manchester. There is a van that if you are a smoker or an ex-smoker, you're invited to go to sort of be screened for lung cancer. They're hugely successful, and essentially what we've done is try to offer people over 65, so they've finished the screening program, a urine test to see if they're HPV positive or not, because these people will not have been tested for HPV, first of all, so they've been tested in the old way. If they've not been for screening, they're still at risk of a cancer. We know there's a spike in cancer incidence in the 70s, especially in those that haven't been screened. So we're opportunistically offering them a urine test. They're giving us their urine. If they're positive, we're then doing a cervical sample and then seeing them in clinic. And interestingly, we have actually had somebody who has been exited the screening program and who has actually come back with high-grade disease that we've treated. So, this is exciting stuff, as in this could really be a big game changer. Why do we finish screening at 65? No one has an answer. I think we just chose it. And also, I guess, in the 80s, when we started screening, people maybe weren't living that long, but people are living longer and healthy and happy. So it would be a shame for them to get a cervical cancer. So we can intervene. So urine could be a really good option for these people, especially as, the speculum examination is more uncomfortable as we get older. So that's what we're doing. That is a cake that I made with a collie pea. It is a lemon cardamom cake with a lemon curd. That is not urine, because I would be really worried if someone was producing that urine. But thank you so much for all the team. It is an absolute pleasure to be part of it, and this is really exciting stuff. So if you can help us and help advertise all the things we're doing, that would be amazing. Thank you so much.
Any questions or comments or offers of we?
Yes. Anyone? Everyone's like, no way.
Anybody want the cake recipe?
It wasn't that good. I attempted a vegan cake and then I was like, it needs eggs.
That was food. Never mind. Thank you very much. Thanks for coming. So we've all earned another coffee break to deal with all the blood flow to the bowels after lunch. So we'll have a short break and then we will resume with Richard Edmondson on the 100,000 Genome Project. Thank you.